So I am super excited to chat with Dr. Roy Steinbock. We're going to be talking about thyroid conditions in children. Very interesting conversation. Even though I have a practice where I see mostly adults, I do see some children, but it's great to speak with someone who focuses. I know we'll talk about you seeing some adults too, so it's not exclusively children, but you definitely see more pediatric patients than I do. So great to have this conversation. And let's go ahead and dive into Dr. Roy's bio here. So Dr. Roy Steinbock, and also I should mention, Dr. Roy is a repeat guest. As recently I had him and his wife Debbie on the podcast as we chatted about the elemental diet. And so you definitely want to check that interview out. So Dr. Roy Steinbock is a board certified pediatrician with an integrative and patient-centered approach. With over 20 years in primary care, he built a solid foundation assisting patients and families dealing with a diverse range of medical conditions. He believes that investigating the root cause rather than only addressing symptoms is the best route to achieving and maintaining optimal health and well-being. In 2006, Dr. Roy founded Mindful Pediatrics so that he could combine evidence-based Western medicine with a functional and mindful approach. It is his own nutritional, spiritual, and lifestyle choices that complements his pediatric practice and continues to influence his approach as a physician. So his degrees include a Bachelor of Arts with honors from UC Berkeley and a doctorate in medicine with honors from the University of Tel Aviv, Sackler School of Medicine. Dr. Roy completed a pediatric residency at the Schneider's Children's Hospital in New York. And since residency, he has worked as a pediatric inpatient doctor in a newborn nursery and neonatal intensive care unit, in several pediatric emergency rooms, and for a large pediatrics private practice in Denver. He has completed advanced courses in functional and integrative medicine and maintains a lifelong passion for learning. What an impressive bio. Welcome, Dr. Roy.
Thank you. Thank you. It's always funny hearing someone else talk about you like that.
Yeah, no, you've gone through a lot of training. Again, excited to talk with you. And I mean, usually I tell people if they could give their background, but we kind of did give you background. But if you
Yeah.
want to expand a little bit, and I'm curious, why did you decide to name your practice Mindful Pediatrics?
Yeah, it's a good question. So, and it's funny because now mindful is really like a household term. But when I named my practice Mindful Pediatrics a little over almost 20 years ago, people didn't even have a clue what that was really at the time. So I had gotten I've always been really a bit of a seeker, kind of spiritual seeker. And I actually got turned on to sort of Eastern philosophy, Buddhism, really in my college years. I meditated regularly, but it wasn't until actually the year before I opened my practice that I actually got turned on to the Vipassana meditation. I did a couple of these silent 10-day retreats. And that's really what inspired me to kind of quit my job at a big pediatric practice in Denver and start my own thing and really do it the way I wanted to do it. And so it just, mindfulness it's an approach to life, and it certainly has influenced my approach to medicine. I think it's part of my meditation and mindful practice is a lot of what informs the decisions I make day to day in my practice. It keeps me focused and present and all those things. So it just felt appropriate at the time, and I think still does, actually.
Yeah, it makes sense. And then one thing when it comes to your training, especially with pediatrics, in medical school, your residency, did they get into any functional medicine or any nutrition, anything about actually improving children's health, or was it really just about I
No.
mean, obviously it's some sort of wellness, but not really when it comes to diet and
Yeah,
stress management
not
and
in
proper
medical
sleep.
school. So like in medical school, it's really, so I always joke that my nutrition course was nutrition pathology. So it's like things like beriberi and scurvy, and rickets, which I actually have seen. That's maybe the only serious nutritional deficiency I've seen during my career. But because and then in residency, you learn a lot about like children's wellness and well-being and things like that when you're doing training. Especially I did like a primary care track. So I did a lot more work in primary care practices because I knew that's what I wanted to go into initially. But it was really my own personal interest. So I've always been a bit of an athlete and interested in my own personal health. And I've experimented with different diets kind of growing up through, high school and college and afterwards. And so when I finished residency, I just realized I had this big gap in my knowledge base. And so I started taking courses in nutrition, and that led to meeting naturopaths and chiropractors, people that, I'd never even heard of a naturopath, believe it or not, until I finished my residency. And then I started meeting all these other people who were kind of practicing more holistically. It also was right around the time that Andrew Weil came out with his first real big book, not to date myself, but and I read that and I was like, oh, this is exactly what I want to do. Of course I want to look at everything. Why wouldn't you look at the whole picture? That seems like any doctor would want to do that. But nutrition was really the gateway for me. And then I learned about supplements and herbs and functional medicine testing.
Yeah. And then in your practice, of course, your wife, Debbie, handles most of nutrition. So I'm sure you have some basic conversations with I don't know so much the child, but also the parents is there most of the time when dealing with with children and I guess teenagers as well.
Absolutely. Yeah. Because I'm fortunate enough to have what I would argue is one of the best nutritionists on the planet in my actual practice, it's a little bit different. So I do talk about basic stuff with people. Really what I do more is sort of the diagnosis, come up with a bit of a plan, but I really rely on Debbie. She's really the boots on the ground to kind of get people to make the changes. She's amazing at meeting people where they are and then really getting them to move forward with their with their lifestyle. So I don't have really long conversations. And again, it's also age appropriate. Like little kids, it's oftentimes you say one thing and they don't remember it the next minute. Yeah. Teenagers, it depends on their receptiveness. And even Debbie works frequently, mostly with the parents, depending on age.
Yeah. Yeah. When I do work with a thyroid patient, sometimes the child isn't even on the call. It depends, like you said, on the age. If it's a teenager, maybe. If it's someone like 13, 14, even in that case, they might not. Maybe they'll make a brief appearance. And then, with you, yeah.
Yeah, agreed. It's sort of the same thing with me. So, I always like to do a physical exam. So they'll come usually for the first appointment, unless it's like a distance, educational kind of thing. But then oftentimes I won't see the child again for, a while, 3-6 months, depending on what labs we do. The kids don't want to hear all the lab results most of the time. Again, unless it's like an older teen or someone who's really precociously interested.
Yeah. And actually I was going to ask, because the example I was giving you, I'm pretty much working remotely with people, but you're seeing people in person. So, if you're seeing at least for the initial visit, you'll have the child and the parent, I'm sure. But do you do follow-up telemedicine visits as well, or do they always come in?
No, I do both. So I'd say probably about 50% of my practice right now, and it really is growing because COVID and sort of people's receptiveness to telemedicine. About 50% of my practice is telemedicine, even the initial visit. It really depends on the kind of the subject, what's going on, the issues going on with the child. Some things absolutely need to be seen in person and some things don't. But I do a lot of even distance consultations. They're different because as a medical doctor, I have a license in Colorado, so I can only practice medicine in Colorado. But I do give like second opinions and help people out, work with their doctor in other states very frequently. That's a big part of my practice now. As you get more, for yourself, as you get more specialized and get expertise in specific things, people seem to find you for those specific things. So,
yeah, makes sense. And how about as far as the free, have you seen a greater, and this is getting into the thyroid side of things, have you seen a greater number of children with thyroid conditions, and especially autoimmune thyroid conditions like Hashimoto's and maybe somewhat Graves?
Yes. For me in my practice, absolutely. I think it seems like the numbers are increasing, but interestingly, when I've talked about it with colleagues of mine who are endocrinologists, they say that there isn't really an increase. And I've looked online, tried to scour the internet and see, it's not really clear whether it's really increasing. It seems like autoimmunity in general, if you're practicing with patients, seems like it's increasing. So I would argue it is, but part of it might be, again, selection bias. Just people come to me when they have a lot of problems, second opinions, people who are not getting diagnosed, in their first round of seeing doctors. And then, and I've become much more aware of it. In all fairness, both Debbie and I both have Hashimoto's, so that's, I think, made us a lot more expert at understanding. And we've done our own research, and both have very strong family histories of it. So, but I do think in general, I just see more sicker kids in general, a lot more autoimmunity than I saw early on. And again, maybe some of that selection bias, just because it's that's tended to become what people have gotten good results with in my practice, and then they tell other people, so then they send people who are sicker to my practice. But yeah, it seems like it's on the rise to me, certainly.
Yeah, I agree. And you mentioned maybe not just children, but just autoimmunity in general. So you'll see, since you focus more on the pediatric side, it would make sense that you see more children, and maybe with the endocrinologist, if they're seeing a mixture of adults and maybe some children, they just don't notice as big of a difference as far as, just focusing on the children. But I would agree, just with the toxic world and the stressors that we've dealt with over the years and other factors, I think just overall, in both adults and children, that there's been an increase in not just Graves, Hashimoto's, but autoimmunity in general.
Absolutely. Yeah, it seems
Yeah.
pretty obvious to me, but again, it's I only have my sample size. Yeah.
Yeah.
I
So
think, go ahead, sorry.
no, that's okay. What were we going to say?
I lost my train of thought on what I was going to say.
No, that's okay. I was going to ask about the diagnosis. So is there a difference between diagnosing thyroid conditions in children compared to adults?
Not really. Oh, what I was going to say is, this will tie into the diagnosis piece. Thank you for reminding me. Is that thyroid's tricky. So, and what I mean by that is that people really can have symptoms before their labs show up as abnormal for a long time. And actually, people can have really abnormal labs because thyroid is, unlike adults, where it's much more standard to do a screening annual lab test. People don't typically do that with children in general. And then even when they do, they don't typically look at thyroid, even a TSH, as a test. It's not really a screening test for kids. And because if you look at the symptoms, particularly for Hashimoto's or even Graves, it encompasses pretty much every system in our body, right? Everything from, your joints to your energy level to, in kids, very commonly growth and development and school performance, anxiety, mental health. So oftentimes people are just missing the diagnosis for many, many years before. And that's maybe part of the reason why endocrinologists don't see this rise, is because it's really just, there's such a lag between symptom onset and diagnosis oftentimes for children and adults. In terms of the testing, it's not really different. I mean, what I do, for me, anyone who comes into my practice and is suffering pretty much from any condition that's either chronic or new onset, unusual, not something obvious like a strep throat or, a tummy bug or something like that. I mean, I'm talking about people who are coming in with longstanding or really acute new onset symptoms that don't make sense. I'll check thyroid. And that I really start with it, depending on what it is. If it's not very serious, oftentimes I'll just start with a TSH or a TSH and then the free hormones, free T3, free T4. But if I'm really not sure what's going on, I will also check thyroid antibodies, both the Hashimoto's antibodies, the TPO and antithyroid globulin, and then also the thyroid stimulating. Because what I've seen frequently in kids is that if you catch it early enough, very frequently they'll have both TSI, so Graves antibodies, and Hashimoto's antibodies. And then usually if you wait long enough or miss the diagnosis early on, they'll generally just end up having Hashimoto's. But that's one of the reasons sometimes you won't see an elevated TSH right away, is that they're actually getting stimulated by the thyroid stimulating immunoglobulins or antibodies. And so their TSH actually looks normal, but they're not feeling well. And I don't know about you, but I found that people, even just when they have high antibody levels, even if their thyroid numbers are normal, sometimes they're still not feeling great. And that might be particularly early on, the first signs. And if you do early treatment, then oftentimes you can get them to improve much more quickly than obviously if you wait till their thyroid is really out of balance with an elevated or a really low TSH. So that's kind of what I start with. And then, of course, start looking for things like, why does this person have an autoimmune condition? And that's where I really get more into like stool testing, allergy testing, nutritional testing. I've found that I have kind of like what I call like my deal breakers. Like if these things aren't balanced, you can't really expect the body to work well, particularly the immune system, both for kids who are getting sick a lot and then kids who have allergies and eczema and asthma, hyperimmune system type stuff, and then autoimmunity. So I'll, at a minimum, look for things like vitamin D deficiency, which is shockingly common. I just saw someone who had a vitamin D of 10. I've had one lower than that, was 9 before in my practice. But, that's like levels where you can actually have rickets. It's really, really, really low, especially living in Colorado, which is so sunny. And then I'll also look for really important at altitude, but I think at sea level too, is iron storage. So ferritin. We don't see a lot of anemia here because people have a higher amount of EPO or erythropoietin. That's why people train at high altitude, because we have higher hemoglobin levels. Like average is more like 13 or 14 versus like 10 to 12, which is at sea level. And so the definitions for anemia don't really apply so well here at altitude. So I have to check things like ferritin level, iron storage. And even if you're not anemic, but you have low iron storage, it seems like that really affects immune system, sleep, nervous system, development, all of that stuff. So I'll aim to work for that to get those elevated. And then zinc seems also like one of those real deal breakers. If zinc is really low, I find that people's immune system just doesn't work well. And zinc is really involved in cell turnover, again, growth and development for children. So those are like 3 basics that I check for anyone coming in for basically any condition, besides optimal health. I think those are great places to just start. And then again, looking at things like stool testing, and it depends. It depends on what's going on, obviously, but it can get out into the weeds with mold testing and all that stuff too. But
yeah,
that's not where I start.
That makes sense. So vitamin D, iron panel, and again, like you said, you can't just go based off of a CBC. And if someone doesn't have anemia, and that's true in general too. Even it's not everybody with an iron deficiency has anemia, even if they're not living in a higher altitude. So I like to test pretty much with all my patients. I like to look at a full iron panel with everybody, and ferritin, if it's elevated, that could be related to inflammation. So you can't just conclude someone has iron overload based on that. So, and then
exactly. And that's why I will look at a CBC and a ferritin at the same time, because especially with kids who get sick so frequently, because even if you just have a cold, your ferritin level can be elevated as in a kind of acute phase reactant. So
I was going to ask, with zinc, do you just do like a regular like serum zinc, or is it like an RBC zinc? Or
I like RBC zinc. I've kind of dove into the research on this, and I have never really gotten into the hair analysis, though, actually, because you see a lot of mental health stuff. I'm actually thinking about starting to do it specifically to look at lithium levels, because there's not great ways to measure lithium otherwise. But in any event, yes, I do an RBC zinc. I think RBC zinc reflects a longer time frame, whereas serum zinc, I think, can really change pretty dramatically depending on what you've eaten and what your it's more moment to moment. So I think as like an acute thing, maybe serum zinc is better, but I prefer red blood cell zinc. And I know that's a little bit debated, sort of what the best form is, but that's the one I've had the best luck with.
Yeah, no, I agree with you. Same thing with like magnesium. I prefer RBC magnesium over serum magnesium. And then there's selenium. I don't know. Do you ever test selenium levels? Or
no, I don't. Do you do that? Is there like an RBC selenium level to test?
There is. I can't say I recommend RBC selenium to everybody, but that is an option. There is RBC selenium along with magnesium and zinc. So
yeah, I do. I think the reason my logic for it is why to check that is, first of all, the red blood cells last for about 120 days, so it's giving you a bigger time frame. And then we also know that the majority of zinc is found intracellularly anyway, right? So I think like it's 10 to 1 amount of zinc in the cells versus what's in the serum. So it just reflects a larger volume of what's in our body and functionally what's being used, I think.
Yeah. And you said, so let's talk a little bit about some of the other tests. So, and it sounds like it varies depending on the person, but like food sensitivity testing, sometimes stool testing.
Yeah.
Uh,
So I
yeah.
would say the kind of like, so first and foremost, anyone who's got any autoimmune condition, excuse me, I will check a celiac test. And we do know there's a very strong, excuse me, there's a very strong association between autoimmune conditions and your propensity to have another autoimmune condition, especially thyroid and celiac. I think there's almost like a 20% connection between celiac disease and thyroid conditions. So that's number one. And again, celiac's really one of those things because it's the yield of treatment. Like if you catch someone who has celiac, it's such an easy fix. And the cost of the test is not very high. So I tend to do those a lot with anyone, again, with chronic health issues. But especially with someone with thyroid. So I'll do like a full celiac panel, and in that I include, both the tissue transglutaminase and the deamidated antigliadin antibodies. I'll look both for those, and of course a total IgA as well, just to make sure that they're not IgA deficient. And then I'll do sometimes like more food allergy or food sensitivity panels when those seem appropriate. And then I'll do a stool test virtually on everybody. Everybody who comes in for a thyroid condition, just because the gut is so important for immune regulation and inflammation. And oftentimes that's kind of the first place to really look. Actually, the first kind of functional medicine course I ever went to, do you know who Patrick Hanaway is? He used to be
from IFM Institute of Functional. Yeah.
Yeah. So I randomly sat with him at a lunch and started talking to him. I didn't even realize who he was at the time, the bigwig and functional medicine that he is. And he just, he saw I was kind of fresh with it. And he basically said, do yourself a favor, focus on the gut first, like learn everything you can about the gut first. And that's what I did. And that's obviously paid huge dividends in the end. It's still really the mainstay of my practice, digestive disorders, of course, but then all the kind of, the things that follow it, like things like autoimmunity. So I really focus on gut health. And that's really was Debbie's initial expertise as well. I mean, it's really expanded over the years, but it's a big part of our workup.
Yeah. And we'll make sure to include the link to you and Debbie, because that focus, the interview spoke about the elemental diet, which relates to gut health. And so we won't get into great detail about that here.
And that could be such an amazing thing for people who are like in flares of autoimmunity or even to calm things down. So
yeah. Okay. So gut test, a comprehensive stool test on everybody, food sensitivity testing, depending on the person. And then maybe some other tests. How about, speak of elemental diet, SIBO, like SIBO also, I assume you don't do it on every single person, but if you suspect maybe.
No, and I think kids have, I think, a lower incidence of SIBO in general. But I do test it. I mean, it is a frequent test I do. If someone's coming in with thyroid, if I diagnose someone with a thyroid condition and they have any digestive symptoms, and they're old enough, obviously, because, I've had some kids with Hashimoto's and Graves' disease who are like under 2 or 3 years old. So it's very difficult to do a SIBO test on those kids. But anyone who's old enough, I might do a SIBO test. Again, it's not my first thing. I'll do a stool test first. If the symptoms make sense, then I will do a SIBO test. Or if I'm not getting results from the basic stool test, then I will do a SIBO test as well. Again, because of Debbie's practice and her focus on small intestinal bacterial overgrowth, that's kind of been in my consciousness, maybe more so than it would be had I not been married to her and, hear everything that she teaches me. So I think I'm a little bit more aware of it than maybe the average pediatrician, but it's still, I think I see it much less frequency. I get more negative tests than, let's say, Debbie does. And part of that, I think, is patient selection as well.
Yeah. And then circling back to the thyroid, when do you get uncomfortable with the TSH? Obviously, TSH alone, you can't just rely on that. And like you said, there could be other variables like the thyroid stimulating immunoglobulins. But some I would argue most doctors, including pediatricians, endocrinologists, they don't pay attention until the TSH is above the lab range, like 4.5 or 5, depending on.
Or even higher. Yeah. I mean, if you look at some of the recommendations some people say in pediatrics not to treat until the TSH is above 10. And that seems
Wow.
crazy to me. I really focus on, I was taught in medical school to focus on patient symptoms. And if the symptoms make sense, so obviously, a couple things with that, Eric. So one is that kids tend to run higher TSH, and it makes sense if you think about what the thyroid is doing. So thyroid is really intimately involved in development and growth and energy in the body. Kids are using a lot more energy. They're growing, so their thyroid is working harder. So that would make sense that your TSH would be higher to stimulate your thyroid gland to produce more thyroid hormone. So you have to be careful. If you look at standard, what normal TSHs are in the first few days of life, like 15 to 20 can be normal. I mean, really high amounts of super high TSH. But then quickly within the first few weeks, it does normalize to closer to adult levels. That's sort of like at least what the standard endocrinologist will say is like, 0.5 to maybe 5. What I do in my practice is, when it's adults, and we can talk a little bit about how the type of adults that I treat in my practice in a minute, but when it's adults, I do kind of try to stay between that 0.5 to 2, maybe 1.5, depending on how someone's feeling. But with children, you have to kind of let it go a little bit higher, again, because of their just natural propensity to have higher TSH. So if someone has like frank hypothyroid symptoms, constipation, cold intolerance, their hair's falling out, super dry skin, really, extreme fatigue, things like that, anxiety, then I would probably treat at a lower number than, let's say, if someone was asymptomatic. Or kind of like what they would call like that subclinical, which I don't really love the term for that. But in any event, what I would say is, so I'll base it mostly based on symptoms. If they have thyroid antibodies, obviously, I might be quicker to treat than somebody who is not. Most of the patients that I'm putting on thyroid either have like frankly elevated TSH, like above 5 or 6, even without thyroid antibodies, or I've diagnosed them with thyroid antibodies and then I see their TSH creeping. So I'll kind of watch it over a period of time, watch their symptoms. If their TSH is kind of 3, 3.5, I might just watch it if they're not having symptoms. But if I start seeing it creeping up to 4, 4.5, 5, then I'll start treating sooner than later. Because I don't necessarily want to wait for them to feel terrible before we start treating them, especially if they have antibodies and their thyroid numbers are creeping up, their TSH specifically. Yeah. So that's kind of how I do that. And the other interesting piece is, though I myself take natural thyroid, I take NP.
I was about to ask you this.
Yeah, I kind of assumed you would ask this. I found that actually particularly because we know that thyroid conditions are much more common in females than males, and that's very true with children as well. I think it's like almost 10 to 1 in children as well. And I definitely see that. I mean, the number of boys that I've seen with thyroid conditions have been a handful, whereas I would say I can't count the number of girls that I've seen in my practice, particularly peripubertal. We see obviously a lot near hormonal changes. So, there's the rare kid who gets thyroid condition at 2 or 3 or 4, but for the most part, it's like 11, 12, 13 for girls. I found that during that time, it's really challenging for me, at least with what I've been able to, tell. It's harder to control them with natural thyroid than just using synthetic, just T4 only. And so though I did use that for years, I just found the ups and downs during puberty are really challenging to manage for girls with hypothyroidism. So once I switched to using synthetic only, it's still hard, but I feel like it's less difficult. And so I'll do that. And then if they're doing amazing, I'll just leave them on that. But if at some point we have additional symptoms, things that typically we think of with low T3, like hair loss or insomnia, things like that, then I might add in the natural thyroid or switch them. If someone's doing really well, I don't like to make changes. Obviously, we want to keep them happy and thriving.
That makes sense. So adults like yourself, usually you're going to recommend the desiccated thyroid hormone, whereas with children, you find on average they seem to do better with like levothyroxine.
Yeah. And the adults I treat are really specific. So I it's not like I have like a general adult practice because I am a pediatrician. I do see a lot of young adults. So people who are like college age, maybe into their like mid 20s. That's a pretty common, especially living in a college town because we have CU, literally minutes from my practice. because a huge part of my practice is focused on mental health, and so many young adults have a lot of anxiety these days, that's been kind of like a gateway into my practice for young adults. But actually the main, and a lot of them have thyroid conditions too. I mean, anyone with anxiety, and I would say anxiety might be the number one way that I've diagnosed kids and adults with thyroid conditions. It's really been, insomnia, anxiety, panic attacks, new onset, particularly new onset extreme symptom versions of that. But the number one people I treat are moms in my practice, because as they come in and I'm asking them how they're doing, and of course I care about how the moms are doing, in order to be able to take, of course, because they're people that I care about, but also because they're taking care of the children, which is my number one focus. And you start asking them questions, and I've had many moms tell me like, I can't go in public anymore. I'm having panic attacks. So then I'll do my workup. I'll do, those things that I mentioned, like the nutrient deficiencies. I'll start with, of course, a thyroid with full thyroid antibody panel. And it's amazing how many of them, I have probably diagnosed more moms in my practice with thyroid disorder than actually kids over the years. I mean, I'm pretty positive it's probably double the number of moms. And then I'll end up monitoring them and treating them if they want. And usually they seem to want that. So, yeah. And oftentimes it's so bad that, we really need to treat the anxiety very intensely, like maybe even use medications for anxiety just to calm it down until we get the thyroid balanced. And then almost invariably, I find that we can get them off of like an SSRI or something like that if once their thyroid, usually within a few months of their thyroid being balanced, their mental health improves dramatically.
Would you say that most of the moms that you work with thyroid conditions have children with thyroid conditions, or not necessarily? I mean, I'm sure you see some which seeing their children for something completely something else, or a wellness visit, and then you just end up diagnosing the mom. So
yeah, so I would definitely say that not most. I mean, the majority of, so many, like 1 in 5 women have Hashimoto's or some thyroid condition, and maybe it's even higher numbers than that. So no, not 1 in 5 kids end up having it, or, most of those people have multiple kids. But I would definitely say there's a higher propensity for, and we know this, right? There's some degree of genetic component for autoimmunity in general. And Hashimoto's, we do see runs in families for sure. My mom has it. I've got a very strong family history, as does Debbie's family. So I'm more cautious, I would say. Like when I see someone who's had, thyroid cancer or Graves' or Hashimoto's, when their kids come in, I will do more regular screening, even if they're totally well, because I do think, again, the earlier you catch these things, the better it is, and the less likely they're going to have any serious long-term problems. And we will focus more on things like diet and lifestyle things that decrease the risk of autoimmunity, maybe more so than I would for the average, healthy kid without a family history. So there's definitely an increase, but it's a relatively small increase. Again, because mostly we see thyroid conditions really develop around puberty, for women, puberty, pregnancy, postpartum, menopause. Those are like the big risk times. Obviously it can happen anytime, but, and that's much later on in my, kids typically come to me when they're very, very young. And then, so maybe around that time, there is an increased risk, and I will see more, of course, in families that have thyroid conditions.
Okay. Graves' disease. So I know you see a lot more people with Hashimoto's, a lot more children, as well as moms with Hashimoto's, just because it's much more common to have Hashimoto's when compared with Graves'. When you do have someone that you end up diagnosing with Graves', do you usually refer them out to an endocrinologist, or do you actually prescribe anti-thyroid medication for the few children, or the children that you have seen with Graves' disease?
Yeah, usually I do refer to an endocrinologist for that. I'll do like the initial workup, because one of the things I like to do, and I'm curious your thoughts on this, but I do really like to do thyroid ultrasounds on anyone who ends up coming positive with antibodies. Obviously, anyone who has goiter, like enlarged thyroid, I'll do an ultrasound on them. But I know it's not the standard recommendation. I think that's partially monetary, financial. I think that maybe it doesn't make sense to screen everybody financially as a gigantic population from a, public health perspective. But I think as an individual, it makes sense, in my opinion. And you want to make sure that there, are no significant nodules to follow and things like that, right? So, and in the odd case, I've had one patient only, but one patient who had ended up having thyroid cancer at a very, very young age. So that alone is worth it, in my opinion, because that could have been easily missed, and that could have been very life-threatening for this poor little. It was actually a little boy who's doing amazing now. But yeah, in general, with hyperthyroidism, I find it's so much harder to treat, and that's why I often will consult with you if I need to. But it is just harder to treat. There's it's so much easier just to give thyroid replacement if your thyroid's not working, and then work up like why the causes, the whys, and how do you improve symptom relief. But when the thyroid's overactive, I will try herbs. I will try herbs, and sometimes I've had some success. But unfortunately, if you wait long enough, most of the time the Graves will burn out. But I've had a few patients where it doesn't, and they've needed either thyroidectomy or radioactive iodine, unfortunately. But yeah, it's a little out of my scope, I would say, to prescribe the thyroid suppressing medications, just because they do have their own risks, and it's something I feel more comfortable when endocrinologist follows. I will also follow them as well. Now, if someone does get eventually turn into Hashimoto's, oftentimes they stop seeing the endocrinologist and will just continue with me. It kind of converts from Graves to Hashimoto's, which is common.
Yeah. And is that what you meant by when you said most people, what the patients you have seen with Graves, when they burn out, where they actually
that's what I meant. Yeah,
exactly. Hypothyroidism. Yeah,
exactly. Yeah. So, and I've seen it in moms quite a bit as well, because particularly with postpartum thyroiditis, oftentimes you'll have both thyroid stimulating and the thyroid
Hashimoto's antibodies.
Yeah, exactly.
TPO and thyroglobulin. Yep.
Mm-hmm. Yeah, exactly. So, but then fortunately, most of the time, eventually, if you can just wait it out and use some supplements or maybe even thyroid suppressing medication, you can wait it out and that will switch over. But then there's a handful of people where it doesn't. And it's not something I see a ton of. And because of that, I prefer to have the endocrinologist involved.
Yeah, no, I get it. And I do agree with you with the ultrasounds, as far as I mean, especially if someone has an existing thyroid condition, or you suspect they have a thyroid condition. I mean, they're not that expensive when compared to other diagnostics. And when I dealt with Graves, the endocrinologist I saw actually recommended not to get an ultrasound, and I talked her into getting me one. I was paying out of pocket, so I think she was just trying to save me money. But it was like 200 at the time. This was,
I think it's still about $200, because I do one every once in a while for myself. Debbie and I will do them for ourselves, and I think she just did one a year ago, and it was like $200.
Yeah, so to me, it's cost effective, even if you have to pay out of pocket. And I would think the insurance companies will pay if there's justification. If someone has a thyroid condition, to me, that's justification. Such, like you said, try to rule out if someone has thyroid nodules, or does it look good? And if it looks good, maybe that will be the only ultrasound they need. But yeah, I'm glad you brought that up. Anything else? I know we covered a lot, but want to make sure that I didn't. Is there anything I should have asked you that I didn't ask you, or again, anything else you want to cover when it comes to thyroid health and pediatrics?
Yeah, I mean, I would say, and I mentioned this before, but I sort of like the take-home message, if I could tell anybody who's either, a parent or a practitioner, is that I think you have to look at thyroid very, very liberally, to test it. Because again, considering the list of symptoms, I mean, just spend a moment on the internet and Google symptoms of Hashimoto's and Graves' disease, and it literally can be almost anything. It really can. I mean, everything from like joint pain, to the more obvious symptoms that we know of. So I just very liberally look for it. And if you look, you'll find it more frequently than you think it is there. And, again, maybe the most common, it could be patient selection for me, selection bias on the type of people who find my practice. But I would say anxiety is really the number one way that probably the most common patient that I find that has thyroid problem is a patient with relatively new onset anxiety or significantly worsening anxiety, coupled with things like insomnia. So those are patients that, and if you look, I mean, I have not studied the DSM-5, the newer versions, but when I was in medical school and doing my psychiatry residency, I was very interested in it because mental health is a huge area of interest for me. And ruling out thyroid disorder is like a mandatory pretty much for every mental health condition. And so it's not done. I don't think a lot of psychiatrists will do blood tests on patients, but I think it absolutely needs to be ruled out. And so, I think if your child's struggling with really any kind of new weird symptoms or chronic onset symptoms, thyroid testing is not super expensive, and it is one of those things that if you catch it early, you can really prevent certainly problems in the near future, but maybe even problems really long term. The thyroid's really just that important. So I think that would be my take home message is when in doubt, you should just test it, because the tests aren't perfect, but they're decent. And if you get positives, you absolutely want to address it. I would even argue relatively aggressively.
All right, definitely agree. Thank you so much, Dr. Roy. And where can people find out more about you?
So you can go to our website. It's mindfulfamilymedicine.com, or you can go to mindfulpediatrics.com or even drroy.com. You'll find me. But that's the main place to find us. We don't really have a real presence on social media at this point, and I don't know if that's ever going to happen. But in any event, our website, we've got a great newsletter and lots of free information on the website.
All right. Well, wonderful. Well, this was a great conversation. Again, thank you so much for sharing, and continue doing the amazing work that you do.
Thank you. Likewise.